I'll be presenting the three speakers. I'll present a little bit about pain, and then we'll have three speakers, each one from different disciplines. They will present the management of pain from their perspectives, and at the end we will have a session for a few minutes for questioning and answers. Let me go ahead and start. The first speaker is Dr. Daniel Lonergan, and he is a clinical director at Vanderbilt Interventional Pain Center at Cool Springs. He's assistant professor of anesthesiology, Vanderbilt University Medical Center. And the second speaker is Ms. Rebecca Warr. She is assistant professor Ida V. Moffitt School of Nursing, Stanford University. And the last one for this session is Dr. Timothy Atkinson. He's a clinical pharmacy specialist, pain management, Department of Veteran Affairs, Tennessee Valley Healthcare System. Let me start by going over the objectives. First of all, we need to discuss the value of an interprofessional approach to pain management in older adults. It's not one aspect. It's not only pills or medications. Usually it should involve different disciplines and best done by a team. We'll describe the components of pain assessment in the Alzheimer's patient and how to assess that. Differentiate among the various chemical classes of opioids used for control of pain. Summarize recent guidelines, updates pertaining to pain management in older adults. And discuss physiologic changes in drug metabolism with aging and how will it affect medications, especially pain medications. First, we have no disclosures, all the speakers in this session. A little bit about pain. If you see elderly adults, you notice that pain is a common symptom or a common complaint. But it is, most of the time, it is untreated, and basically because mainly for three reasons. One of them is that the belief that old age comes, or pain comes with old age. They should have osteoarthritis or back pain or whatever, and pain, yeah, it's expected. Second is that the fear of addiction, and a lot of physicians, they are afraid that the patient will be addictive. Even I've seen cases who are at the end of life, and the physician is still afraid of prescribing more pain medications. Oh, I'm worried about the addiction and things like that. And also lack of routine assessment, pain assessment, especially in patients who may not be able to communicate, like having a CVA or having Alzheimer's. They may express their pain in a different modes and ways, and if they are not assessed well, they may be left untreated for a long time. Now, what will happen if this pain is untreated? Really, there are a lot of negative effects. Some of them, it may cause depression, it may decrease functional impairment, anxiety, sleep problems, withdrawal, behavioral problems, and I've seen residents, especially in nursing home or even at home, patients transferred to inpatient psych because being agitated, and turn out they are having pain. Now, as you all know, the Joint Commission of Healthcare Accreditation of Healthcare Organization has mandated that healthcare assessment should be with the vital signs, and it is the fifth vital sign, and it should be taken on every patient. And that's why the nurses now, they do very good job in assessing pain, but the physicians still, they don't do very well job. I mean, I can speak, not all of them, definitely, but still they don't. Oh yeah. I mean, that's fine. Okay. Now, there is a growing problem that a lot of older adults, they misuse prescribed medications, and they may self-prescribe medications, especially pain medications. And it has been found by SAMHSA. They did a survey in 2012, and they found that 336,000 of elderly misused or they were dependent on pain relievers. And this was an increase of 132,000 a decade earlier. So there is an increase in misusing. And misuse, it's not abuse. Misuse is like they're using the medication not as directed by a physician, or they are using it for different reasons. About 25% of older adults, 50 and above, use psychoactive medications, especially opioid and benzodiazepine. Also, according to the data collected by the IMS, Intercontinental Marketing Services, they found that 55 million opioid prescription for people above 65 has increased by 20% over 5 years. So there is a trend of increasing of prescription of more opioid drugs. And also at the same time, it has been found that the annual emergency room visits by elderly people above 65 for drug or pharmaceutical misuse increased by 50% from 2007 to 2011 to more than 94,000 a year. So it is a problem which kills a lot of financial, it causes a lot of medical, functional impairment in elderly, and it's growing. And it can be either the one side being untreated, to the other side overtreated or overprescribed. Saying that, I will go ahead and start in presenting the first presenter, Dr. Dan Lonergan.
Thanks. It's good to be with you this afternoon. All right, so let's first talk about the title of this presentation, because I think it's good to discuss these things. And I talk with almost every patient about this, because a patient comes in and sometimes the first question I ask them are, what are your goals? Why are you here? And it's very common that I have a patient tell me, Doc, I want you to end the pain. You know, I'm not that kind of doctor. And actually, we hopefully don't have any of those in the United States. We cannot end people's pain, right? What they mean is they want me to help them manage pain. Some patients do have the unrealistic expectation that we can end pain. Pain is obviously part of mortality. So the first thing I do with patients is try to help them set reasonable expectations for their treatment and to make sure they understand that there's no chemicals and no treatments that will just completely take away all their pain. Very few chronic pain conditions have straightforward solutions. And especially by the time people get into my office, those solutions have already been sought and have either failed or we don't have any good surgical or medical solutions to people's pain. Some of these situations are really complicated, and they can be frustrating for physicians. Family members get frustrated. The patients get frustrated. It's very common that I have a patient and their family members come in and they're very upset because they feel like the medical community has not treated their pain. And sometimes it's just a misunderstanding about what we're able to do and what's available to us as physicians. And sometimes their pain really has been mistreated or undertreated. A lot of these difficult, complicated situations require interdisciplinary management. So that's what I want to talk about today is, as a pain physician, what's in my tool belt? So when I see a patient, what are some options that I'm thinking of? The first thing that we always think about, medications, probably because sometimes these are easy options for us. Sometimes that's what patients expect. There's not a chemical solution to every problem. Many patients, especially in the newer generation, might think that, but sometimes chemicals can cause more problems than the original problem they're intended to treat. Geriatric patients are especially sensitive to both the beneficial effects of medications and also the side effects. And my goal isn't to really discuss medications in detail because I know a later speaker will do that, but I just want to review some of the classes that I think about when I see a patient. First of all, the anti-inflammatory medications. These can be very effective if the pain is inflammatory pain. A lot of patients have already tried over-the-counter pain relievers, ibuprofen, naproxen, and they may be helpful or they may not be. I'm typically thinking of three problems with anti-inflammatories. One is gastritis or peptic ulcer disease. I'm also thinking about acute kidney injury, and I'm thinking about cardiovascular risk factors. I just saw a patient on Friday, yesterday. She said, "Don't take my Celebrex away." She's 80 years old, and she says, every doctor tries to take it away. Don't do it. And I said, okay, I'll leave your Celebrex alone. She understands that she has cardiovascular risk factors and that Celebrex increases those. She literally told me that she would rather die than not take Celebrex. So, we're always making compromises with patients, and that's not a problem at all. Sometimes I'll have a patient come in that they're eating ibuprofen. They'll say like, oh, I take 20 or 30, or actually I lose count. I don't know how many I take in a day. So then I'm looking at, okay, how can we stop these bad habits that could be dangerous for a patient? So a lot of times I'll go to a medication like meloxicam, which is once daily dosing, every morning, scheduled, and I just tell a patient, I say, look, this is your dose of anti-inflammatory. Don't take anything else. And there may be risk factors associated with that, but it's a lot less risky than them taking bottles of ibuprofen every month. So a lot of times we're just trying to compromise, we're trying to assess risk and educate patients about the risks and let them make a decision with you about the best treatment option. Anticonvulsants, these have become very popular for neuropathic pain. Gabapentin, Lyrica, carbamazepine, oxcarbazepine, Topamax. So these are very good for neuropathic pain syndromes. If someone has postherpetic neuralgia or even a lumbar radiculopathy, these can be very helpful medications. In the elderly population, you do have to be careful about side effects. You can have especially side effects of sedation, dizziness. Patients may not tolerate these medications because they're so sensitive. So in an elderly patient, I'll start at very gentle doses and may titrate very slowly. Sometimes patients that may be intolerant to medications, I'll start gabapentin, but just give them a nighttime dose, maybe just 100 milligrams or 300 milligrams, and see how they do over the course of the month, and then see them back, and if they're tolerating it well at night, then we may try some small daytime doses as well. Some patients are just happy because they're able to get a better night's sleep without so much pain. Along with that, the antidepressants, the tricyclics, often are very good for neuropathic pain. They can also treat depression, obviously, which is their initially intended use, but can have a lot of side effects, anticholinergic effects, and a lot of patients don't tolerate these. So if you're starting a patient on amitriptyline or nortriptyline, you might just start a very gentle dose, like 10 milligrams at night, and just see how they do and make sure they don't have any serious side effects. The SNRIs, Cymbalta and Savella, have become very popular for generalized pain and fibromyalgia and can also help treat depression. So these things are very popular. And I've found that a lot of patients do tolerate these pretty well, and they have a fairly good side effect profile. Again, especially in the elderly population, you want to start at low doses and titrate gently with them. Muscle relaxers, in general, I'm not a big fan of muscle relaxers. I think they're okay for acute pain syndromes, but I try to get my patients away from these for chronic use. Of course, I do have patients that use them chronically, sometimes because we can't really find other options. The biggest problem with muscle relaxers is they're so sedating, they're associated with falls, a lot of side effects. Soma can be very habit forming. I don't even prescribe Soma anymore because I think there's some better medications available as muscle relaxers, and the habit-forming issues I don't want to deal with. Occasionally I have a patient that's done well with it for a period of time, and I may continue with them on that. Same thing with benzodiazepines. As muscle relaxers, they're just not a great option. You might decide to use them for an acute lumbar strain or something, but for chronic use, especially in the elderly population, I just think you really need to be careful with the benzodiazepines. That being said, if someone comes in and they've been on them for 10 years, you don't want to just take them off, because that can be dangerous as well. So I'm always trying to find good solutions and make compromises with the patients. But in general, I'll try not to introduce them to soma or benzodiazepines and try to find other options. I could give an hour-long lecture on opioids for the treatment of pain. We could probably sit here and talk about it all day long. I think really you need to determine what your goals are. Do you think the patient is appropriate for opioid therapy? And then you assess them frequently, make sure there's no evidence of abuse or diversion, make sure they're having a good effect from the medications. You can see there the 4 points that I listed. These are called the 4 A's, and these were developed by Steve Pasek. And analgesia, you want to make sure they're actually managing their pain. Activities of daily living. Are they helping the patient to be functional? Especially in the elderly patient, that's oftentimes our goal. How can we make you more functional? How can we help you to enjoy your life more? Are the opioid medications contributing to that or not? Are they having intolerable side effects? A lot of patients just don't tolerate these medications. You'll try them on various opioids because they have severe pain, and they become too constipated, or they become too sleepy, or they don't like the way it makes them feel. They just, in general, don't like it. We tend to stereotype people with pain, and oftentimes we think that maybe people are drug seeking, but oftentimes, really it's only 20 to 30% of these patients that even will tolerate an opiate. So it's good to find other solutions, and if you feel like they need an opioid, then try it and watch them closely and make sure they're doing well. Some cases I'll consider detoxification. Obviously in a palliative situation, or if someone's very elderly, sometimes these aren't really good options to introduce to people, but some people do really well just getting off their medications. They have a good response. Topical medications can be really helpful. There are pharmacies all over the state of Tennessee that compound medications. One of the biggest barriers is insurance coverage. But some patients decide these are so helpful they'll even pay out of pocket a monthly fee and have a pharmacy compound these for them. Non-narcotic skin patches. Herbal remedies. Patients often ask me about Chinese medicine, supplements. I'll often recommend alpha-lipoic acid and acetyl L-carnitine for diabetic neuropathy. B vitamins, fish oil. I think all these things are great things for patients to try. I think they have very low risk associated with them, as long as they're not going to be a financial burden on the patient. Encouraging them to try these things because they may be helpful, and it's a safe, easy way to help somebody in a small way. Physical therapy, TENS units can be helpful, traction, aquatherapy, myofascial release. I've even been exploring starting a fitness program with my patients that we run from the clinic to try and help people move and be active, because a lot of pain, especially myofascial and musculoskeletal pain syndromes, are just associated with people not moving enough. Psychological counseling. I always am careful with patients when I suggest this, because I don't want them to think I'm saying they're crazy. Maybe they are, but in a lot of cases I'll recommend this, and I don't think they have any psychiatric problems. I just think that a pain psychologist could really help somebody cope with their pain and learn to manage it better. And our psychologists teach a lot of great techniques for people to help deal with their pain on a day-to-day basis that don't involve more chemicals. These things are really helpful. I have a couple psychology interns that work with me in the clinic, and they see patients 2 days a week, and just the patients being able to talk to them is really helpful. They spend 20 or 30 minutes talking with a psychology intern, and they feel better when they leave. That's, in my opinion, that's really good medicine. Alternative medicine, I'm always asking patients, are you doing yoga? Are you doing Pilates? You interested in acupuncture? Acupuncture, I'm a big fan of it. We have a really good acupuncturist at Vanderbilt Center for Integrative Health. And I try to make sure the patient believes in that sort of thing because I don't want them to waste their money. But if a patient really is interested in an Eastern medical philosophy and they think that might be helpful, that I would definitely recommend it. I recommend chiropractors. Obviously, if my patient has severe cervical stenosis, I tell them to stay away from spinal adjustments. But in a lot of cases, I will recommend chiropractic adjustments. We do in our clinic a lot of, not a lot, but some trigger point injections for people with very specific myofascial pain. Botox injections for patients with migraine headaches and cervical dystonia. Epidural steroid injections. These really get a bad rap because of the fungal meningitis outbreak, but these can be done safely, and these can be extremely helpful for people with certain types of low back pain, specifically radicular low back pain. If you have a radicular nerve irritation, then epidural steroid injections can be helpful. And I had a few case studies that we don't have time to address. Nerve ablations. You're probably hearing patients ask about this because it's become more common for arthritic type low back pain. Not the radicular type that's shooting down the leg, but people with just low back facet arthritis. We can burn these medial branch nerves and sometimes gives people significant relief. And a lot of times these last 9 or 12 months. They don't always work, but I'd say 75% of the people that I do these on report a positive result. And then there's even much more aggressive treatments. If someone's had a lot of surgeries on their low back and they still have pain, or they have complex regional syndrome or some sort of debilitating pain syndrome, we can do nerve and spinal cord stimulators, which are implanted devices that actually intercept pain signals as they travel to the brain. And on even a more extreme end, we can implant intrathecal pain pumps to deliver medication to the site of injury. And these can also be very helpful. So to recap, there are a lot of options that we can think about. We do have a nice tool belt to use. So if you have patients that you think an interdisciplinary approach would be helpful for, go ahead and get them to a pain specialist, and we may be able to help. Thank you for your time.
Thank you, Dr. Lonergan. Now I would like to present Ms. Rebecca Warr. She's an assistant professor of nursing at Stanford University.
Good afternoon. I'm going to address assessment of pain, and this is going to include pain for the cognitively impaired older adult as well as with a patient with dementia. We've talked about percentages of older patients with chronic pain today, so I think it's safe to say that, I think I've just messed that up. Sorry. There we go. Okay. It's safe to say that patients over 65 do suffer from chronic pain, and depending on what literature you read, sometimes it's upwards of 90% of the older patient. Why do we care? Of course, pain is not a pleasant symptom, but chronic pain can lead to depression, sleep disturbance, decreased mobility, increased healthcare utilization and just stretching of services, physical and social role dysfunction, just people not being able to do what they want to do, and severe untreated pain can lead to delirium. Yet pain is often overlooked and undertreated. Common causes of pain, and this list isn't exhaustive, it's just what the most common causes are. Musculoskeletal pain tops the list when you think of things like arthritis, osteoarthritis, low back pain, circulatory problems, shingles, certain bowel diseases, cancer, and diabetic peripheral neuropathy. So I'm going to ask you to take about 5 seconds, maybe 10 seconds, because I do have a limited time, to find a partner, if you just turn to the person next to you, and without talking, assess a friend. Just look at them and see from your powers of observation, are there any physical signs of pain? So y'all are on the clock. Go. Yeah, no talking. I think that was one of the rules. You know, nurses, we like to follow rules. Okay, time's up. That's not fair. I didn't give y'all much time, did I? Y'all were kind of cheating a little bit, too. Y'all were talking. Anyway. So you were using your powers of observation to assess, and I hope none of you had any severe pain going on. If you had a blood pressure cuff and a stethoscope, you might have checked each other's blood pressure. You might have checked pulse rates. I don't think I saw anybody checking pulse rates. But there's one author in particular who suggests that you can have pain and you always have signs of physical symptoms. And I'm not going to tell you whether I agree or disagree with that, and y'all are free to have your opinion about that. But usually blood pressure is going to be increased about 130 to 90, over 90, and pulse rate of 88 beats per minute. Pupils usually dilated, and the hands and feet would be cold. So what you probably saw in each other, what you were looking at, was body position. If you got a chance to talk, you might ask if they had insomnia. They might complain of not being able to eat if you could talk to the person, or they might have diarrhea. Well, on this slide, the top two pictures kind of show you a picture of pain. And if you knew nothing else, if you just looked at those pictures, you would probably say, those people are in pain. And they're demonstrating that body posture. There's an asymmetry to their body posture. There's grimacing. The man has this look on his face that he's looking straight ahead. So that's a clue that he's in pain. Now, hopefully what we all look like is the happy guy on the bottom doing his exercise. So I hope that's what we're all looking like today. There's some other behavioral indicators of pain. Groaning, grimacing, guarding a body area, teeth clenching, rubbing the body area. The picture of this lady here, she clearly either has a headache or some sinus problems or something. We can tell she's in pain. And so I think those are pretty self-explanatory. It starts getting to be easier to miss when you have things like agitation and restlessness. That could be caused by pain. It could be caused by other things, but we should think about pain if we see those things. Irritability, increased confusion, combativeness, especially with activities of daily living, changes in appetite, changes in usual activity. And sometimes it's not the patient themselves who tells us this, it's the caregiver. So caregiver information becomes very important. And then it becomes even harder to detect these subtle symptoms. Is someone sleeping excessively? It makes sense that people can't sleep when they're in pain, but to have somebody say, well, my mom is sleeping all the time, and say, oh, well, that's a pain symptom. And it could be that they're just so exhausted from the pain that they're sleeping a lot more than usual. Inability to sleep, rigid body posture, just increased rigidity if they're already rigid, repetitious vocalizations, or if they're already having repetitious vocalizations, is it more than usual? And then any repetitive movement. And again, it gets to be the surrogate reporting that may be the thing that highlights to us that there is a pain problem going on. We've talked a little bit about, in the introduction, some of the common myths, and we have to be aware of those when we're looking at pain assessment and to make sure that we are not falling into that, believing those myths and ignoring pain. Okay, so the gold standard for assessing pain is to say to the patient, are you hurting? Are you in pain? And as health professionals, we like to get things on a number system, a scale. So that numeric rating system, the 0 to 10 scale, I think most people are used to using. And to say to patients, 0 is the least pain you can imagine, and 10 is the worst pain you can imagine. And they can usually give you a number, especially with cognitively intact patients. With the patients who are less cognitively intact, the FACES scale is very helpful. And just that figure of 6 faces, and to ask the patient to point to which one represents their pain level, even patients who cannot communicate well can a lot of times point to the face that represents them, and to be quite accurate. Both of these scales have been found to be valid and reliable. Even among cultural groups, and the FACES pain scale, you would wonder, is that reliable among different cultural groups? It was tested with whites, African Americans, and Koreans. So among those groups, it was found to be valid and reliable. And then you do want to explore the pain, get a description of it, the location, the quality, the onset, the duration, what makes it better or worse, just exploring what's going on. And then also to ask them what their functional goal would be. And then we also look at their ability to respond. That might be a question. If they have cognitive impairment, you can use the mini mental state exam and get some information about where they are as far as dementia. I think it's interesting to note that even with dementia, up to a moderate level, they can respond to the question, are you in pain? And they may not be able to verbally respond, but they can point to a chart or point to the FACES scale and indicate that they do have the pain. So when it gets to the moderate to severe level of pain, that might be the tricky part of assessing that there is pain there. So here's just a list of the assessment tools that you can use, and we really do need to use an arsenal of tools. Some people who are cognitively intact and even moderately in a moderate stage of dementia may be able to answer the numeric rating scale, but some of these other tools will help us, and we need to keep those on hand for those who cannot verbally respond. So here's the visual analog scale. And then I'd like to talk just a little bit about the pain assessment in advanced dementia tool, and that is conveniently called the PAIN-AD scale. It's much easier than saying its full name, but it's based on certain behaviors that you look at in the patient. So you're taking maybe a minute, maybe up to 5 minutes to actually look at the patient, and you're assessing their breathing. If they have no problems breathing, they would get a 0 for the score. If they have noisy breathing and they're struggling to breathe, they would get a 2. And just going on down the list, negative vocalization, where they're repetitive and troubled and crying out, they would get a 2. On down, the facial grimacing, if they had no facial expression, they would get a 0. Of course, there's a 1 level there, but if they have facial grimacing and they're looking pained, they would get a 2. And consolability, are you able to distract them, keep them from crying? They might get a 1. If they had no crying or didn't need to be consoled, they would get a 0, but if they're inconsolable, they get a 2. And so when you total all those aspects up, it actually comes up to be a total of 10 if you make a 2 in each of those. And so that does correspond to that 0 to 10 scale, which is very convenient. Another scale that is used is a discomfort behavior scale. And this was based on the minimum data sets that's used quite frequently in nursing homes. And so that might be something that people are used to using. And it has been found to be valid and reliable, but it also has been found to be skewed towards the lower end for a negative pain. So if the person has one response that says they're in pain but nothing else, it's suggested that with this scale, that needs to trigger more searching and more in-depth exploration of whether the person has pain or not. And if they did have a positive, at least one positive response, then maybe going back and using the pain add tool would be a good alternative. The FLAC Behavioral Pain Assessment Scale has been found to be useful not only in older adults and older adults with dementia, those who were unable to verbalize, but also with children aged 3 years old. So you run the gamut on this one. And it's pretty much like the pain add scale, and you're looking at the person, and they suggest that you look at the patient undressed, uncovered, not undressed, with the sheets off of them, and that you're looking for 1 to 5 minutes so that you're seeing what their body movement is like. They suggest you do that while they're doing some kind of activity, some kind of movement, because that would bring out the pain more, that you could more easily observe. So you would look at the person, and if they're asleep, they suggest that you touch their muscles to see if they have tension. And you could score. And again, when you total up each of these items, it's going to get to be a 10 if they score on each of these at that 2 level. And so it correlates to that 0 to 10 scale. Okay. So what if there are no visible signs of pain, but this person has a condition that we know to be painful? If we know they have arthritis, are they in pain just because they have Alzheimer's or dementia? We say no, they don't, because they have no expression, they have no movement. In 1993, there was a research study done, and they were looking for markers of in the cerebrospinal fluid, and they found that when lumbar puncture was done, cognitively intact patients complained of headache, about 40% of them. And that makes sense. So we know that it probably is going to cause pain. Yet only 2% of dementia patients reported headache. And the researchers said, is that because they feel no pain or because they're unable to communicate the pain? So he suggested more study. Well, there have been other studies that have been done more recently that suggest Alzheimer's disease patients with dementia do have pain. In one study, they did a painful activity with electrical shock, and it was found that Alzheimer's patients did not have the anticipatory response to that. They couldn't anticipate, even when a person told them, you're going to get this electrical stimulus, then they had no anticipation of that. Cognitively intact patients did anticipate. If they told us we were going to get an electric shock, our blood pressure and pulse would go up. The patients with dementia did not. They suggested that Alzheimer's disease patients do feel pain based on that, and they were looking at brain activity is how they measured that. And then a more recent study has found that pain is actually maybe more distressing for those with dementia. They were given a painful stimulus and measured with MRIs, and with the MRI, the pain persisted, or even after the pain was gone, and cognitively intact people, it looked like the pain had gone away, when indeed it had. So they're question was, is it more distressing for a patient with Alzheimer's to be in pain? And I think that kind of points out that we do need to be aware of treatment of pain. So about 33 to 40+% of dementia patients are untreated, just given no pain medication. And so does a patient without behavioral signs of pain actually experience pain? They probably do, based on those studies. So if a condition is known to be painful, we should go ahead and treat even without their ability to demonstrate that they are in pain. Okay. And I think I have a slide that says questions, but I think that will come later.
Thank you, Ms. Warr. Now, before I present our third speaker, I would like to remind you, for the third speaker, we want you to use the clickers, which are in the green bags on the tables. It will be more interactive session. Now I would like to present Dr. Tim Atkinson, PharmD. He's a clinical pharmacy specialist in pain management for the VA Tennessee Valley Health System, and he recently finished his specialty residency in pain and palliative care. Please welcome Dr. Atkinson.
Good afternoon, everyone. So last year in 2013, there were new guidelines released for the management of pain in the elderly. And I'm going to be covering and doing a brief update of some of the medication options and changes and recommendations that they had, and incorporating some clinical pearls and suggestions that they had for practice. This was an interesting way to present the evidence, I thought, as a series of general principles for the pharmacologic management of pain in the elderly. And the first one was that due to the physiologic changes of aging, that this increases their sensitivity to medications. So we should be using lower doses of medications, particularly to initiate treatment because they're more sensitive, and then titrating to response. Also, the incidence of side effects in the elderly with drug therapy is much higher. This is partially because of the physiologic changes, partially because of polypharmacy, but they did want to reinforce that analgesics can still be very safe and effective if used appropriately. This is kind of a busy slide, but just to kind of go along with the previous point, 49% of all hospitalizations for medication-related adverse effects occur in the elderly. So it's an enormous portion of hospitalizations in the elderly compared to their percentage of the population in general. Obviously, reasons for this are polypharmacy, with the elderly having an average of 8 to 10 prescriptions per patient on average these days. There's a lot of drug interactions and a lot of potential for that when you have so many medications. But the table here that is also here kind of demonstrates some of the physiologic changes of aging. And a lot of these particularly affect drug therapy. Typically, on average, their percentage of body fat increases, muscle mass decreases. Particularly with drug therapy, we do see increased GI transit time, making a big difference in drug therapy, as well as a higher incidence of hepatic and renal dysfunction. One interesting thing is that because the number of liver cells actually decrease, their ability to metabolize medications also decrease, potentially resulting in their sensitivity to medications. We should be using the oral route whenever possible for convenience, and it's the least invasive. Only one drug should be initiated at a time, and this should be the lowest dose possible, and should be a slow titration. We see this all the time in clinical practice. It's very tempting when you see multiple medical problems to initiate several treatments at once. But then when we run into adverse effects, it can be very difficult to separate out which medication and which treatment that has been initiated is actually causing the problem. And then we see multiple medications at once that may be added to a patient's adverse event or allergy list when that may not be appropriate. And that could limit their medication options in the future. Just as important, though, is to allow sufficient time and intervals between introducing medications. It's very common to initiate a medication and in terms of kinetics, the medication has not even had time to reach its full therapeutic effect, and we're already considering increasing it. That can also result in increased adverse effects if it is increased too quickly. So our first clinical pearl from the guidelines is that tricyclics, which Dr. Lonergan already introduced for us, can be a very effective class for neuropathic pain, and it is often used in pain management. But in the elderly, these are contraindicated or should only be used with extreme caution. And the reason for this is because they have a lot more side effects than other agents that we could potentially use. Some of the common side effects that can be particularly troubling for the elderly patients are urinary retention. It can worsen orthostatic hypotension, sedation. It can worsen fall risk, which is a huge part of managing pain in the elderly. And one of the major issues with this class of medications can be cardiac arrhythmias, particularly lengthening the QTC interval, which can be a problem. So for these reasons, the newer class of agents, the SNRIs, or the serotonin norepinephrine reuptake inhibitors, these are the agents like venlafaxine, duloxetine, milnacipran, desvenlafaxine. These are antidepressants, but they can also be used for pain. The reason that they're preferred is not necessarily because they're more effective, but they have a much better side effect profile, a lot less toxicity, particularly in the elderly. So this brings us to our first polling question. And the question is, which of the following medications are tricyclics? And your answers are potentially cyclobenzaprine, promethazine, amitriptyline, or venlafaxine. Please go ahead and enter your responses now. I'll give you a few seconds before we close this. It's okay to guess. All right. A couple more seconds. Go ahead and hit a button. Okay. It looks like most of you have selected amitriptyline. Amitriptyline is a tricyclic. That would be a correct answer. But look at this. We have some people that think that they're all tricyclics. And also almost as many people selected both cyclobenzaprine and amitriptyline. Well, let's just see how this turned out, shall we? These two chemical structures look almost identical. I imagine most of you said, did we really sign up for a chemistry lecture? What I want to illustrate here is that these two chemical structures are nearly identical, and the double bond in the center ring is really the only difference. But functionally, how they interact with the receptors in your body are almost identical. So while we may recognize the risk for amitriptyline, we may not as easily recognize the risk in our elderly patients for cyclobenzaprine, which is a muscle relaxant that is commonly prescribed and can be just as sedating and increase a patient's fall risk. The next one is that the timing of medications is important. This is a really important point because the type of pain medication that we prescribe for patients, it really should match the kind of pain that they have. If a patient has severe episodic pain that's perhaps once or twice a day, it may not be appropriate to prescribe them a long-acting or an extended-release medication, and they may not like that. If it's a sudden onset, then a short-acting agent that has a rapid onset is more appropriate. However, if they have continuous pain, then regular analgesia is more effective. But this should be discussed with the patient. We should understand how often they have pain, how severe it is, and And again, as Dr. Lonergan said, the goal these days is not to over-medicate, but to provide enough medication so that they can function and accomplish their daily activities. There is a limit to what medications can accomplish, and if we rely solely on medications, then we quickly run into a wall with pain management. Some other considerations for opioids. Some poor choices in chronic pain management is if we rely solely on short-acting medications for patients that have pain all the time. This is because they have short-acting medications, they're in the body and they're out. They're in and they're out. There's higher peaks, which are associated with higher toxicity profiles, particularly in the elderly patient that is more sensitive. Oftentimes, the best results are found by keeping the amount of medication as low as possible and as steady as possible to decrease those toxicity profiles and their fall risk. One longitudinal study that the guidelines cited was in a nursing home that found that extended release opioids improved functional status and social engagement in patients compared to immediate release opioids. Again, I would caution that this needs to be individualized and that all opioids should be considered a trial and not permanent. The fear of addiction, which was referenced previously, is a serious concern for both patients and providers. And it's interesting that generationally, in my experience, the World War II generation and earlier tend to fear this more than others. But in a review of 3 studies with over 25,000 patients of long-term opioid therapy, and these patients had no history of substance abuse, only 7 cases of addiction were found. It is typically, and that's, I think, the key, in a patient with no history of substance abuse. And what often happens in our day in healthcare is a patient comes into your care and may selectively eliminate or withhold part of their history, okay? And then we do have to be cautious of that and pay attention to those signs. These are some of the longer-acting or extended-release opioids that are available. We're not going to spend any time on those. So here's our next question. This one will be almost as much fun. So which of the following does not require monitoring blood levels? So which medication can you prescribe and you will not have to monitor blood levels? Try not to shout out the answers for your friends. Okay, we'll give you about 5 more seconds. Time to hit that button. All right. Let's see. Survey says gabapentin. Absolutely, that is the correct answer. And that brings us to our next clinical pro from the guidelines. The anticonvulsant or anti-epileptic class can be very effective in treating neuropathic pain, but again, this needs to be done as safely as possible. In the elderly population, where they're very sensitive, medication classes with more adverse effects truly need to be avoided. In this case, they recommend avoiding the older anti-epileptics, which are carbamazepine, phenytoin, and valproate, okay, among others. But these medications require monitoring blood levels. They're effective within a certain therapeutic range. They can be toxic above that range. And in particular, in the elderly, where drug interactions are a serious, serious concern, these can all be a problem, particularly medications with a high degree of drug interactions like carbamazepine or phenytoin. Both of these are inducers. And what that means is they chew up and spit out the other medications that the patients are taking. So you could potentially be compromising the rest of the medications that a patient is taking merely by prescribing these 2 medications. These days, the first-line therapy is recommended for, if you're going to use an anti-epileptic for neuropathic pain, is gabapentin and pregabalin, which is Lyrica. These are both actually very similar medications, believe it or not. I know that Neurontin, gabapentin, has been around a long time, whereas the pregabalin or Lyrica has not been around as long. They actually operate on the same receptor in the body. One of the interesting things here is this is actually often a great option for patients with neuropathy or nerve pain because gabapentin and pregabalin do not have drug interactions. They do not have drug interactions because they are not metabolized by the liver whatsoever. So they are excreted by the kidneys entirely unchanged. This is both wonderful in terms of drug interactions, and it can also lead to potential problems if we're not aware of that and understand that what that also means is that in our elderly patients that have a very high risk of kidney dysfunction, somebody who has compromised kidney dysfunction or chronic kidney disease does not eliminate or get rid of these drugs as easily, and they can quickly result in a lot higher degree of adverse effects. So that is something that it does have to be accounted for with these medications. In addition, these medications must be started low and titrated to effect. Otherwise, it's very common with these medications that patients will be very, very tired and very dizzy. This is particularly true of gabapentin. Again, Dr. Lonergan did a great job of explaining this, and oftentimes it requires starting very, very low, and it could be a month or two before there's even a therapeutic effect. However, it is important that we start low and go slow with these medications. Gabapentin in particular, this is an issue because it has decreased GI absorption. So it seems like the patients are taking an enormous amount of medication, but a lot of it is not getting absorbed. Pregabalin, on the other hand, as a newer medication, overcomes some of these challenges with better absorption and a little bit higher affinity for the receptor. Oftentimes, that can be switched out. Combination therapy. This is something that we like to talk about in terms of combining separate medications to achieve synergistic effects. I would caution you about this, though, however, because this can result in greater pain relief, which is what this is talking about. However, what I tend to see in practice is you start multiple medications trying to address a certain kind of pain, and inevitably someone comes along and says, well, this isn't working as well. He has this kind of pain. Let's increase this. And then pretty soon you have several medications at higher effects with obviously the risk. This is just a demonstration of what that would look like. And as Dr. Lonergan also talked about, it is very important that we talk to our patients about the limits to what medications can accomplish. Okay, that they need to be addressing their medication. I don't know if you know this, but the FDA criteria for approving a pain medication in this country is 30% pain relief. So their expectation is that we can really only accomplish about 30% of a person's pain, and the rest of it we're going to have to address elsewhere. Okay, last polling question. This one's my favorite. Which of the following regimens will test positive for opiates on a standard urine drug screen? Please select your answers now. About 5 more seconds. Okay. This should be interesting. Okay. Most of you selected all of them because it is, after all, they are all opiates, right? Well, the interesting thing here is that they all have different cutoffs for detection. And this was a little bit of a tricky question, and I'm not going to apologize for that because I'm mean-spirited. But when we look back at the question, okay, when in a urine drug screen, when it says opiates, what it really means is morphine, okay? They're testing for morphine. Hydrocodone, oxycodone, and other medications in the same class, they're included by default, but at higher cutoffs. And that means that someone who is on hydrocodone, it may take substantial doses for that to even show a positive result. And that really depends on the cutoff that your lab has. As prescribers, it is extremely important that you know those cutoffs, because if it is a high cutoff, like what we're seeing here on the screen, 1,700 nanograms per ml, that could be anywhere between 60 or more milligrams per day of hydrocodone, and most of your patients are not on that. Okay? So it's very important that you know that. You'll see that oxycodone has a very, very high cutoff. And what that means is that most labs have a special screen for oxycodone to make sure that it shows positive for you, but you need to make sure that your urine drugs test has incorporated that. You'll notice here that fentanyl and methadone are not included. The reason for that is that there are various chemical classes of opiates. The phenanthrene class is the prototypical class with morphine and oxycodone and hydrocodone. Okay, but fentanyl, meperidine are in the phenylpiperidine class. It's a completely different chemical structure. Methadone in the diphenylheptane class is also a completely different chemical structure. Your body recognizes these as different. So unless it is a specific urine drug screen to detect that chemical, it will not show positive. I can't tell you how many times I get calls from physicians weekly asking, should this patient have tested positive? Okay, it is so important that we understand the tests that we're using so that we don't punish our patients, okay, based on what we put them on. And if they're taking it as prescribed, we need to use the tests appropriately. I also want to draw your attention to, this is a great chart and a great reference in terms of understanding allergies with opiates. A true allergy for opiates is extremely rare. Most of the side effects and intolerances that you hear about are tiredness, nausea and vomiting, some kind of cognitive dysfunction. Those are particularly transient. Constipation is not transient. Most of the side effects with opiates typically fade after a week or two on therapy. If they are severe, then we can address that. It may be worth trying something different. However, it should raise a little bit of a red flag if someone comes into your office and says, this is the only opiate that I can tolerate. There are no other opiates. This is the one that works. None of the rest of them do. I'm allergic to everything else. Okay? A true allergy to hydrocodone or oxycodone, for example, they would not be able to take morphine. They would not be able to take hydrocodone. You would really have to switch them to a completely different chemical class, and that's why looking at this can be helpful. While running out of time, I just wanted to mention very quickly to you at the end of this, and I think in your booklet is included these charts at the end, because hepatic and renal dysfunction are so common in the elderly, it is extremely important that we understand how things are metabolized. Medications with a very high risk of drug interactions within the opiate class are methadone, fentanyl, and oxycodone because they are metabolized by the cytochrome system, which tends to be more sensitive as patients get older. It tends to be, those cells decrease. So medications that are metabolized in the liver via phase 2 metabolism or glucuronidation tend to be less affected by hepatic dysfunction. And it's a little bit more predictive, the response that we're going to get. I know that's a pretty busy slide. So I will thank you for your attention and look forward to your questions.
Thank you, Dr. Atkinson. And we have around 10 minutes for questions. It's your chance now. Yeah, go ahead, please.
With a small hairline fracture, how much education do you all do, and what type of education do you do that you found effective to prevent future falls and pain?
I'll try to address that. The answer is, the question was, do I or my staff, do we address fall risk and educate patients on this? The answer is no, we don't. Should we? Yes, we should. There's a lot of things that we should do, right? And this, we're all frustrated by this. There's so many things that we should do. I have 15 minutes with a patient, and it's frustrating because there's all the, I'd love to have a pharmacologist and a psychologist and a nurse that could educate people, and we just don't do enough of this in our clinics. And the reason we don't do it is because we don't get paid for it, right? So, I'm often in a clinic with just an MA, just me and an MA, and we're seeing 25 patients a day, and it's like, it's crazy. You're just trying to survive. And so you're just trying to get through each patient and give them the treatments. I would love to implement some kind of model where we could have better education about fall risk, about drugs. I'd love to have someone educating my patients about fitness, myofascial pain, and hopefully someday we'll have a medical model where we can actually address these things. So I wish I could answer your question better and give suggestions, but I just don't know how to do it.
I have a question for Ms. Carr. In a nursing home, in an Alzheimer's unit, which one of the pain assessment scale would you recommend? If I am a DON and I ask you, which one would you recommend to assess pain in our severely demented patients?
Well, I think probably starting off with the behavioral assessment scale as a basic screening, but knowing that it skews towards the low end. So if there's any evidence of pain at all that's triggered, then you would have to do that more in depth. And you're really having to look at the whole picture of the patient, not just looking with that assessment tool, but you're also looking at knowing what the patient's diagnosis is, asking caregivers who are with that patient all the time, what is this patient's behavior looking like? Family members, knowing any difference, any change. And I think combining all that information together, my personal favorite tool is the PAIN-AD scale. And I think it gives really good information about pain. But using all those in combination, all that information in combination.
Thank you.
Yes, what would either of you recommend for a patient that has costochondritis? Do I need to define that?
The question was costochondritis, what would we recommend? This is really tough to treat. I also get a lot of patients with intercostal pain syndromes, which is more of a neuropathic pain, probably related to intercostal irritation. So costochondritis, typically we think of more of a musculoskeletal type pain, but also the thoracic neuropathic pain syndromes are really hard to treat, and they're really debilitating for people. I also see a lot of a pain syndrome that I see a lot of, but I've done a lot of research and tried to find this well described in the literature, but a lot of people have really focal pain syndromes just medial to their scapula. Kind of, it's almost like the thoracic version of costochondritis. It's just this horrible pain that people experience. I try a lot of different things. You can try trigger point injections. You got to be careful because the lungs are right there. So sometimes I'll use ultrasound or fluoroscopic guidance. Sometimes that can settle down an irritation, like an inflammatory irritation. The nerve blocks, also the local anesthetic, can sometimes help reduce the neuropathic pain. You can try anti-inflammatories and anti-neuropathics. Try to get people moving, doing some physical therapy. Sometimes just movement, getting people active again can be helpful for at least restoring their functionality. But I don't have any slam dunk solutions for it. Sometimes just encouraging patients, hey, I think this will go away. Let's just do our best and hope it goes away. And in the meantime, let's manage this as best as we can.
Thank you.
Yeah, this question is addressed to Dr. Lonergan. I have a question on diversion. In your practice, how do you address diversion, especially if you suspect that either a family member, a caregiver, or a significant other is involved in diversion?
It's really tough because diversion is really hard to prove. And sometimes I do suspect it when a caregiver comes in with an elderly patient. And sometimes it's just a gut feeling. And you don't want to accuse people because we're very bad at judging people, right? In fact, I have a friend who does Suboxone clinic part-time, and we've been discussing this, how these patients who come in who are opioid addicts are not the people you would expect, right? They look just like all of us, right? And some of the patients that come in and you think they are opioid addicts are not opioid addicts. So we're very bad at judging people. So if I have that gut feeling, and I did this last month, An elderly patient came in with a caregiver, and I had a discussion with her, with the caregiver, and I said, look, this is one of the things I look out for, and I take it really seriously, and I don't think you're doing this, but I talk to everybody about this. If you are caught diverting these medications, taking them for yourself or selling them, taking them away from the patient, I take that really seriously. It's a felony offense. And, I just see how people react. If people are really defensive and offended, I try to do it in a way that they won't be that way. But sometimes just addressing it and opening that discussion can really help. Interestingly, that patient didn't come back, right? So maybe that's just a problem that I identified, and the caregiver said, you know what, we're going to try a different pain clinic where I don't have to worry about this every month, if she really was diverting, or maybe they didn't come back for a different reason. But just address it with people. Tell them that it's a risk. When you have an elderly patient, talk to them about it. Ask them, hey, is anybody taking these medications? They may tell you, yeah, my son takes it. I have to lock it up because people steal it. So just communicate.
We can have one more question.
This is for Ms. Warr. You said that we should treat people who have conditions that should be painful, but what would be the end point? How do we know when we've treated them enough?
I'm not sure I heard the whole question. I'm not sure I heard the end.
How do we know when we've given somebody enough treatment for pain if we can't tell that they have pain?
And I'm not sure I can answer that question. I think the statement goes with being sure that we do give medication for treatment instead of not giving anything. And I'm not sure I have a really good answer about how much is enough. I might defer to the pharmacist on that one. Sorry.
Oftentimes we're obviously talking about somebody with cognitive impairment here and Alzheimer's. I do have a couple of patients in my clinic that come in with their caretaker, and oftentimes it comes down to behavior. Sometimes those problem behaviors are because they're not being treated appropriately. Sometimes, for example, I had a patient with Alzheimer's who they had changed his pain medication, and he was climbing the walls. He was breaking into the electronic medication dispenser, just really having trouble with the change. When his pain was much better controlled, he was much more pleasant. Those behaviors disappeared. Sometimes, and his caretakers can get some sleep. So sometimes that is really the only indication that you're going to have.
Okay, thank you very much, everybody. Thank you, panel.